I'll be presenting another aspect of masquerade uveitis, which initially doesn't require any advanced or multimodal imaging, but all it requires is a clinical suspicion, high index of clinical suspicion in abnormal presentations. So, moving on, masquerades are basically something that hides one's true identity. It's a pretense and it hides what lies beneath. So whenever you see a masquerade, there is something more than meets the eye. In the context of uveitis, the uveitis masquerade syndromes are systemic and ocular pathologies that manifest with intraocular cells, which are not secondary to inflammation. That is the bottom line. Now, most often when we hear the term masquerade, our mind reflexly thinks of malignancy. However, we must learn to associate this term with an entity that could give rise to presence of cells in the aqueous or vitreous, as I have listed here, which could be trauma, intraocular foreign body, pigment dispersion, retinitis pigmentosa, amyloidosis, ocular ischemic syndrome, rhegmatogenous RD. So none of these are inflammatory or uveitic entities, but they do give rise to cells in the aqueous or vitreous. Now, study of cells, it helps greatly with regard to differentiating one non-neoplastic cause from the other in a majority of cases, and modern slit lamps, they provide sufficient magnification and optics to be able to accomplish this. However, once neoplastic masquerades are under consideration, it is the beginning of an entirely new story. So you have to be able to see whether it's a WBC, RBC, pigment epithelial cell, RP cells, tumor cells. So that is most important even before you think of masquerades. Now, when the cells are determined to be neoplastic, it is important to figure out what kind of a neoplasm it is, and there are multiple neoplastic entities which we come across in ophthalmology, like primary vitreoretinal lymphoma, uveal lymphoma, leukemia, and metastatic solid tumors. And in pediatric age group, RB coats, juxtaxanthogranuloma, and medulloepithelioma are also seen. But to get an overview, the uveal lymphoma can involve iris, ciliary body, or the choroid. However, the primary vitreoretinal lymphoma is by definition what involves vitreous body, retina, and the optic nerve. Among this, by definition, up to 15 to 25% of primary CNS lymphoma will have ocular involvement, but this falls outside the definition of primary vitreoretinal lymphoma. And most patients with primary vitreoretinal lymphoma, even with no CNS symptoms, will develop CNS lymphoma eventually, which is quite rare. So, I have just one illustration. A 65-year-old Asian Indian female presented to uveitis clinic. Definition of vision in floaters for 1 year. She had been to many centers, was treated on nearly everything, including intravitreal antibiotics, steroids, PST Kenacort, anti-glaucoma therapy, everything. And she had developed some cataract also. By the time she reached us, she had also undergone a peripheral laser iridectomy. So, when the patient presented to us, she was 618 in right eye and 69 in the other. The IOP was controlled on anti-glaucoma medications. There was presence of pigments on the endothelium with some mutton fat KPs and a patent peripheral iridectomy. There was NS grade 1 cataract, and the angles were open with heavy pigmentation. On fundus examination, there was presence of dense vitreous membranes. So, we did a complete uveitis workup initially, stopped all medications to get a clearer picture that could emerge for us to diagnose. Nothing was contributory, all reports came normal. This picture was when she presented to us, there were few KPs. She was already using topical prednisolone. There was some pigmentary deposition on the lens surface. And vitreous was full of vitreous membranes, which even on retroillumination can be seen. Fundus was hazily visible, disc was visible, and FFA did not reveal any contributory findings. Right eye FFA was not a very good quality due to dense vitreous membranes. OCT was also not possible in order to elicit any significant findings. So, we did consider this as an old vitreous hemorrhage, or maybe a patient who was not clearly diagnosed for a uveitic entity. So we initially gave the patient some time because we didn't want to rush, and because the patient had received multiple treatments. However, as we observed, the patient started deteriorating and the vision dropped from 618 to 160, and she also developed mutton fat KPs and dense vitreous membranes, which increased over time. At this point, we started thinking of unusual entities because everything had been ruled out, and at this point of time I did think of an unusual entity like PVRL in view of a non-resolving dense vitritis with vitreous membranes not responding to steroids. So we started thinking of a zebra when we heard of the hoofbeats, and we planned a vitreous biopsy. B-scan revealed multiple vitreous membranes. FFA and FP had a very poor media clarity, so it was not possible. This is a short video of a biopsy that we performed. Here we can see that the cortical hyaloid is thickened with lot of cellular deposits. You can see the edge of the cortical hyaloid which is being cut. There was one hypopigmented subretinal lesion next to the temporal to the macula. At that time I could not associate any significance to this. There was no vasculitis, there were no other significant findings that could contribute to my clinical diagnosis except for these amorphous deposits which were present on the surface of the retina. So all this I aspirated and sent for analysis. The cytological specimen showed pleomorphic cells with large hyperchromatic nuclei and scanty basophilic cytoplasm in right eye. We planned neuroimaging because there was a suspicion of malignant cells. However, the diagnosis was not very clear at this image. We performed MRI brain, which was reported normal. We performed vitreous biopsy in the left eye, hoping to get something out of it. That was also reported normal. By that time, patient was exhausted and did not follow up for some time, went home or something. Patient came in September again after about 2 to 3 months with recent onset forgetfulness and left-sided headache. At that time, ocular exam was normal. There was no recurrence of cells or vitritis. IOP was okay, so I thought maybe nothing was to be done from our side, so we referred the patient to neurology for a repeat neuroimaging. However, patient was not convinced for a repeat neuroimaging MRI within 2 to 3 months, so they went back home. What happens next was patient lands up in medical emergency after about 3 to 4 weeks with left-sided hemiparesis and slurring of speech. CT scan brain showed this huge lesion lying in the temporal aspect. The patient was taken up by neurosurgery and underwent a left temporozygomatic craniotomy and excision of the tumor. Squash cytology was done, which suggested a high-grade malignancy, and tumor biopsy and histopathology showed neuroparenchyma diffusely infiltrated by neoplastic lymphoid cells. Immunohistochemistry confirmed a diagnosis of diffusely positive common leukocytic antigen positive for CD20 B cell, and it suggested a right temporal diffuse large B cell lymphoma. This patient finally was diagnosed with bilateral PVRL with ocular hypertension, subsequent CNS lymphoma, and which was high-grade NHL B cell. Patient is currently receiving radiotherapy and chemotherapy. She is doing well. She has some focal deficits, residual. However, she's surviving, and she's seeing in the right eye where I had done the vitrectomy and also cataract surgery. We did not feel the need for intravitreal methotrexate because the vitritis did not come back. So the take home would be that all cells are not inflammatory. A very high index of suspicion is needed for picking up masquerades, and in the era of microincision vitrectomy surgery, we shouldn't hesitate to take a vitreous sample if you have the facility of processing. Believe in your clinical judgment, and you do not need fancy multimodal imaging all the time to diagnose such cases. Thank you so much.